All right, let's dive right into this explainer. Today, we're talking about a massive shift in communication and clinical mindset, one that can absolutely transform diabetes care and honestly a patient's overall quality of life. We so often think of diabetes management purely in terms of glucose-lowering meds, A1C targets, and strict clinical metrics. But the latest American Diabetes Association standards of care make it abundantly clear. If we want optimal outcomes, we need a person-centered, collaborative approach. We really have to treat the whole person, not just a disease.
So it begs the question, why might our patients not follow the best clinical advice? We have these incredible, evidence-based treatment plans at our fingertips today, yet therapeutic inertia, when we fail to adjust treatments that clearly aren't working, and treatment discontinuation are still incredibly common. Why does a perfectly crafted clinical plan just fall apart in the real world? Well, the answer usually isn't a lack of medical knowledge on our part. It's actually a breakdown in the partnership between the care team and the patient.
To really put that into perspective, listen to this staggering statistic from our source material. Among people dealing with chronic illnesses, 2/3 of those who skip their medications due to cost-related barriers never share that information with their physician. Think about that for a second. 2/3. If your patient literally cannot afford their medication, but they feel too judged or maybe just too rushed to tell you, your evidence-based plan has failed before they even walk out of the clinic. We have to create an environment where active listening makes it genuinely safe for patients to share those crucial details.
So, to tackle this, we're going to follow a structured pathway in this explainer today, covering the power of language, assessing the whole person, the shared decision cycle, comprehensive medical evaluation, and finally, prioritizing under constraints.
Starting right off with Section 1, the power of language, because words absolutely matter.
Think about the massive difference between our old kind of stigmatizing medical labels and using empowering person-first language. The words we use literally shape behavior and perception. Labeling someone as a diabetic defines their entire identity by a condition. Calling them non-compliant places all the blame on them and induces shame, which of course actively discourages them from seeking help. Instead, the ADA strongly recommends person-first language, a person with diabetes. And rather than non-compliant, we should say they are experiencing barriers. It's a simple tweak, but it completely shifts the dynamic from judgment to collaborative problem solving.
So how do we operationalize this? We look at these 5 consensus recommendations from the joint ADA and Association of Diabetes Care and Education Specialists report. Our language has to be neutral and fact-based. It has to be free from stigma. It needs to be strength-based and actually impart hope because, let's face it, diabetes is a lifelong journey. It should foster collaboration, and above all, it must be person-centered. When you align your vocabulary with these 5 pillars, you build trust, and trust is, without a doubt, the currency of patient partnership.
Moving right along to Section 2, assessing the whole person, which means looking way beyond the clinical data. We absolutely have to talk about social determinants of health, or SDOH. You already know these are the economic, environmental, and social conditions our patients live in every day, and they play a massive role in clinical outcomes. Our sources point to National Health Interview Survey data showing that half of adults with diabetes report financial stress, and about 20% report food insecurity. Look, if we're prescribing a strict diet plan without ever asking if the patient has access to a grocery store, or handing over a prescription without knowing if they can afford the copay, we just aren't treating the whole person.
And as the ADA guidelines explicitly point out, these factors are consistently unrecognized and go entirely unaddressed during visits. This is exactly why we have to prioritize active listening and systematic screening. Things like housing insecurity or a lack of social support can't be ignored. The guidelines recommend using brief, validated screening tools during our encounters, so we can actually connect patients with local community resources or community health workers. Okay, let's shift gears to Section 3, the shared decision cycle, and taking collaborative action.
Here the ADA lays out this really logical step-by-step decision cycle for person-centered management, and notice how cyclical and continuous this is. First, you assess their key characteristics, their values, comorbidities, and those SDOH we just talked about. Second, you consider specific treatment factors, like side effects and costs. Third, you use shared decision-making. You aren't just handing them a prescription, you're discussing the options. Fourth, you agree on a management plan together. And fifth, you implement and review it regularly to dodge that therapeutic inertia. If something isn't working, no problem. You just loop right back to step 1.
Now, when you hit step 4 and agree on that management plan, your targets absolutely must meet these 5 SMART criteria. You know the drill.
Specific, measurable, achievable, realistic, and time-limited. Vague advice like, hey, just eat better and exercise more, simply fails. But co-creating a goal like, I will walk for 15 minutes after dinner 3 days a week for the next month, now that is actionable. It gives the patient clear ownership and a very realistic path to success. Let's dive into Section 4, the essential components of a comprehensive medical evaluation. Looking at Recommendation 4.3, we see the baseline for a complete initial and follow-up evaluation. And man, it is comprehensive. You're confirming the diagnosis, classifying the diabetes, assessing glycemic status, and evaluating for complications. But crucially, as we've been saying, it explicitly requires assessing those social determinants and structural barriers. It's a holistic checklist designed to ensure we leave absolutely no stone unturned in our patient's health profile. To make sense of all those data-dense requirements, let's organize it into a clear clinical flow. What do we monitor initially versus annually? Well, you've got the medical and interval history. You have behavioral factors, checking in on their sleep, eating patterns, physical activity. You do the physical exam, catching blood pressure and BMI. And finally, the lab evaluation. And remember, that's not just A1C. It's lipid profiles, liver function, and kidney tests like the urinary albumin to creatinine ratio, so we can proactively optimize cardiovascular and kidney protection.
Finally, Section 5, prioritizing under constraints, or how we actually apply this in the real world.
Look, we all know clinical practice is squeezed for time. A 15-minute visit goes by in absolute flash. So, to help you prioritize when resources are super limited, follow this synthesized checklist to hit the most vital, person-centered components first. Step 1. Elicit patient preferences and barriers right away using that empowering language. Step 2. Quickly assess for highest risk complications, mainly cardiovascular and kidney disease. Step 3. Do a brief screen for immediate SDOH needs, like severe financial or food insecurity. And Step 4. Co-create just one SMART goal to focus on before their next visit. Doing this ensures that even a short visit is highly collaborative and impactful.
As we wrap up this explainer, I want to leave you with one big question. How will you partner with your patients today? Transitioning from an old, compliance-driven model to a true partnership paradigm doesn't mean you need a whole new medical degree. It just requires a shift in mindset. It starts with the very next words you use when you walk into that exam room, your willingness to ask the tough questions about financial barriers, and your commitment to shared decision-making. Because when you empower a person with diabetes, you aren't just improving a clinical metric on a chart, you're genuinely transforming their life. Thanks for tuning into this explainer. I challenge you to put these tools into practice in your very next encounter. After all, if we don't start treating the whole person, can our healthcare system ever truly heal them?